Every 65 seconds, a woman somewhere in the United States dismisses a symptom that has been quietly building for years. Her eyes have been burning since she woke up. Her mouth feels like sand. She reached for her water bottle 3 times during a meeting and still could not get through a sentence without her tongue sticking to the roof of her mouth. Her doctor told her it was probably just menopause. Her dentist told her to drink more water. And she went home carrying a disease that affects roughly 3 to 4 million Americans and that 9 out of 10 patients will tell you took years to name. That disease is Sjogren's syndrome. And for women over 50, it is one of the most commonly missed, most commonly dismissed, and most systemically serious autoimmune conditions in existence. If that sentence just landed for you, if something in what I've described so far sounds familiar, I've put together a symptom map that shows exactly how this condition progresses, what shows up at each stage, and where the standard tests are most likely to miss it. Type symptom map in the comments right now and I'll send it to you directly. Because what I'm about to show you next is why that map matters more than most people realize, and why the stage you're in changes everything about what happens next. Sjogren's is not a dryness disease. That framing is one of the reasons it stays invisible for so long. Yes, it attacks the glands that produce moisture, including the tear glands and the salivary glands. But it does not stop there. The immune system in Sjogren's is misfiring at a fundamental level, and that misfire can reach the nerves, the joints, the lungs, the kidneys, and the brain. Up to half of all cases in the United States may never be diagnosed or reported. The average time from the start of symptoms to a confirmed diagnosis is between 3 and 5 years. And for women specifically, the symptoms that surface first get routed through the wrong explanations: stress, aging, menopause, depression, or that particular brand of medical erasure where a woman describes a body that is clearly struggling and gets handed a pamphlet on self-care. That misunderstanding is exactly what this video is going to correct. If you want health topics explained in plain language, without panic, and without sugarcoating, subscribe and tap like. To understand why these signs matter, you need a sense of what Sjogren's is actually doing inside the body. The immune system is supposed to target foreign threats. In Sjogren's, it turns on the body's own exocrine glands, which are the glands responsible for producing secretions like saliva and tears. Lymphocytes flood those glands and slowly degrade their function. But the process does not stay contained. Inflammation spreads. Nerve fibers get damaged. Tissue in joints, lungs, and kidneys can be affected. And the underlying immune dysregulation can begin producing symptoms years before anyone connects those symptoms to a single cause. The result is a disease that looks different in different people, that can involve nearly every organ system in the body, and that is frequently treated as a collection of unrelated complaints rather than a unified condition. The first warning sign is the one that names the disease and still gets missed. Persistent eye dryness that does not behave like ordinary dry eyes. Ordinary dry eyes improve with rest, improve with artificial tears, improve when you stop staring at a screen. They are situational. They have a reason. What Sjogren's dry eyes do is different. The gritty, sandy, burning sensation is there in the morning before anything has happened. It does not clear up. It cycles between tolerable and unbearable. Vision blurs not because of a prescription problem, but because the tear film is unstable and collapsing throughout the day. Contact lenses become impossible. Bright light becomes intolerable. Patients describe reaching for eye drops dozens of times a day, and getting temporary relief at best. Comment the word eyes below if any part of this sounds familiar. This is not allergy. This is not screen fatigue. This is the immune system attacking the lacrimal glands, the structures behind the outer corner of each eye responsible for producing tears. And because dry eye is so common in middle-aged and older women, and because menopause does cause some reduction in tear production, Sjogren's dry eye gets absorbed into that category and the investigation stops there. A Sjogren's test, which places a small strip of paper under the lower eyelid to measure tear production, is one of the objective tools used to evaluate how severely tear output has declined. A result of 5 mm or less after 5 minutes is clinically significant. Most women with Sjogren's reach their eye doctor long after that threshold has already been crossed and are still being managed symptomatically without a rheumatology referral. If this video is helping you connect dots you have been carrying for a long time, the symptom map in the description below can help you organize what you are noticing before your next appointment. The second warning sign is a specific kind of mouth dryness that goes beyond thirst and starts affecting the body in ways most people do not associate with their mouth. Saliva is not just moisture. It contains enzymes that begin digesting food the moment it enters the mouth. It neutralizes acids. It physically protects the teeth and the oral tissues from bacterial overgrowth. When the salivary glands stop producing adequate saliva, the consequences cascade. Food that should slide down effortlessly requires water to swallow. Crackers, bread, and rice become genuinely difficult to eat without constant sipping. Speaking for extended periods produces a dry, sticky discomfort. People start waking multiple times a night to drink water because the dryness becomes impossible to sleep through. Comment the word mouth below if this matches what you have been experiencing. And then the teeth start breaking down. Not because of poor hygiene. Because without adequate saliva, the environment inside the mouth becomes acidic and bacteria proliferate unchecked. Women with undiagnosed Sjogrens frequently describe a sudden pattern of new cavities, cracking teeth, and dental work that never seems to end, despite brushing carefully and seeing their dentist regularly. Those dentists, who are often the first to observe the physical signs of salivary decline, rarely initiate a referral for systemic evaluation. The mouth is treated. The disease is not. Xerostomia is the clinical term for pathological oral dryness. And in Sjogrens, it is not a symptom in isolation. It is the most visible output of a gland destruction process that is happening throughout the body. The third warning sign is a fatigue so specific in its quality that the women who live with it describe it in almost identical terms. Fatigue is one of the most minimized words in medicine. Everyone is tired. Everyone pushes through. But Sjogren's fatigue does not respond to sleep. It does not lift after rest. It arrives in the morning already installed, and it carries a particular heaviness that is difficult to explain to someone who has not experienced it. Patients consistently describe it as a flu-like exhaustion. A fog that makes concentrating difficult and that makes tasks requiring mental energy feel like physical labor. Surveying over 6,000 Sjogrens patients, the Sjogrens Foundation found that 90% reported fatigue as a significant symptom. 90%. Comment the word fatigue below if this level of exhaustion has become your baseline. This kind of fatigue gets blamed on poor sleep, on stress, on perimenopause, on depression. And because Sjogrens frequently does co-occur with depression, and because systemic inflammation genuinely disrupts sleep, those explanations feel plausible. They are not wrong so much as they are incomplete. They explain the fatigue as a cause when it is actually a consequence of immune dysregulation that has not yet been identified. One mechanism worth understanding is small fiber neuropathy. The small, unmyelinated nerve fibers that control autonomic functions including heart rate, blood pressure, sweating, and bowel motility are vulnerable to the immune attack in Sjogrens. When those fibers are damaged, the result is a persistent, draining disruption of body regulation that produces fatigue, lightheadedness, and pain that conventional nerve tests cannot detect and that physicians frequently cannot explain. The fourth warning sign is joint pain and muscle aching that does not follow the pattern of ordinary wear and tear. Joint pain in women over 50 is common enough that it rarely prompts urgent investigation. Arthritis is the default explanation. But Sjogren's joint involvement has a distinct character. It tends to be migratory rather than fixed. It affects multiple joints in a pattern that shifts, settling in the hands, wrists, and knees but moving unpredictably. The joints may be painful and stiff, particularly in the morning, without the joint destruction that appears on imaging in conditions like rheumatoid arthritis. 81% of Sjogren's patients in the Foundation's survey reported joint pain as a significant symptom. Comment the word joints below if you have noticed this kind of wandering, unexplained aching. The problem is the overlap. Sjogren's is frequently misdiagnosed as fibromyalgia, as rheumatoid arthritis, as lupus, as chronic fatigue syndrome. These conditions share enough surface features with Sjogren's that clinicians treating a single symptom cluster never pull back far enough to see the full picture. A woman with widespread pain, fatigue, and dryness who sees separate specialists for each complaint may leave every office with a partial answer and never receive the complete one. The fifth warning sign is the one that truly separates Sjogren's from what most people think it is, and the one that gets dismissed most aggressively. Neurological symptoms that seem to have no explanation. Sjogren's is not a disease that stays politely inside the glands. In a meaningful percentage of patients, it reaches the nervous system. Research estimates that peripheral neuropathy, meaning nerve involvement outside the brain and spinal cord, affects approximately 15% of Sjogren's patients. Among those with neuropathy, 83% are women. The neuropathic symptoms can precede the diagnosis entirely, meaning the nerves start signaling damage before the dry eye and dry mouth have even become severe enough to register. Comment the word nerves below if you have been experiencing unexplained tingling, burning, or numbness. What does this look like in real life? Tingling or numbness in the hands and feet that spreads without explanation. A burning sensation along the skin that makes clothing uncomfortable. Pins and needles that do not resolve. Dizziness on standing, heart rate irregularities, and bowel changes driven by autonomic nerve damage. Some women experience sensory changes in the face or scalp. Some experience weakness or loss of coordination. These symptoms walk through the door of a neurology clinic, receive a workup that looks for the obvious causes and finds nothing definitive, and leave labeled as anxiety, functional neurological disorder, or idiopathic, meaning no cause found. Meanwhile, the actual cause continues advancing. Now for one of the biggest myths about Sjogrens in women over 50. If your blood test for the Sjogrens antibody came back negative, you do not have it. This sounds like reassurance. It is not. The anti-SSA antibody test, which is one of the primary markers used in Sjogren's evaluation, is negative in 30 to 50% of people who actually have the disease. A negative antibody test does not rule out Sjogren's. A normal eye exam does not rule out Sjogren's. A lack of obvious dry mouth does not rule out Sjogren's. Because symptoms can involve several body systems without all of them being affected simultaneously, and because the disease progresses at different rates in different people, a normal result in one area of testing does not mean the disease is absent. It may simply mean the testing was not thorough enough, or not targeted at the right systems, or was done before enough tissue damage had accumulated to produce a positive result. Think of it this way. Sjogren's does not stamp a single organ and announce itself. It moves quietly through multiple systems, and the window in which you catch it with standard testing can be narrow. Dismissing the diagnosis because one test was negative is one of the most common reasons women spend years being treated for individual symptoms that are all being caused by the same underlying disease. So what should you do if any of this sounds familiar? The goal is not to panic. The goal is also not to wait. If you have noticed persistent eye dryness that does not respond to drops, oral dryness that is affecting your teeth or your ability to eat and speak, and exhaustion that does not improve with sleep, joint pain that moves and does not have a clear cause, or neurological symptoms including tingling, burning, numbness, or dizziness, write it down. Document what you are experiencing, how long it has been happening, and how it is affecting your daily life. Then bring that information to a doctor and ask specifically for a Sjogren's evaluation. 3 assessments are worth asking about by name. An ANA panel combined with anti-SSA and anti-SSB antibody testing is the standard blood-based starting point, though as discussed, a negative result does not close the case. A Sjogren's test through an ophthalmologist or dry eye specialist measures tear production objectively. And a referral to a rheumatologist, the specialist most equipped to evaluate and diagnose Sjogren's, is the appropriate next step if symptoms persist across multiple body systems. A lip biopsy, in which a small sample of the minor salivary glands inside the lower lip is examined for the characteristic lymphocytic infiltration of Sjogren's, remains one of the most definitive diagnostic tools available, particularly for patients who test negative on blood markers. Your doctor will determine what applies to your specific situation. But asking specific questions is far better than leaving with nothing more than a reassurance that everything looks fine for your age. On the prevention and management side, there is currently no cure for Sjogren's, and that fact deserves to be stated plainly rather than avoided. But early identification matters enormously. Caught before significant gland damage has accumulated, the dryness can be managed with prescription and over-the-counter therapies that reduce the downstream consequences, including the dental destruction, the corneal damage, and the loss of function. Caught before neurological involvement becomes severe, the nerve damage can sometimes be stabilized. And caught before the disease progresses to its most serious complications, including an elevated risk of lymphoma that research now estimates to be nearly 9 times higher in Sjogren's patients than in the general population, monitoring and intervention can make a meaningful difference in long-term outcomes. Hydration matters. Sleep matters. Protecting the eyes and mouth from their most damaging environmental stresses matters. And staying connected to providers who take the systemic nature of this disease seriously is not optional. It is how women with Sjogren's hold the line against a condition that will otherwise advance quietly and without announcement. Sjogren's syndrome is not rare. It is not benign. It is not simply a nuisance dryness problem that aging women should learn to live with. It is a serious, systemic autoimmune disease that affects 3 to 4 million Americans, 9 in 10 of them women, and that remains undiagnosed or misdiagnosed in the majority of those it affects. The warning signs covered here: persistent eye dryness that does not respond to standard treatment, oral dryness that is affecting the teeth and the ability to eat and speak, a flu-like exhaustion that does not lift with rest, joint pain that migrates without explanation, and neurological symptoms including numbness, tingling, and burning, are things worth knowing and worth taking seriously. If any of these sound familiar, do not rely on memory alone. Write it down, bring it to a doctor, and ask for a real evaluation. Everything here is for education, not diagnosis. But your situation deserves more than a general check-in and a referral for a glasses prescription. If this made a complicated topic easier to understand, subscribe and hit like. This channel exists to take health topics that feel overwhelming and make them clear, specific, and actionable.